A very good morning to all of you. And okay, so when I was making the presentation for this class, I took a class on an ALCL in 2018, 3 years back, and this was my last slide. What I expect in next few years, and at that time, Echelon 2 data was not available, and these were the expectation what is going to change in next couple of years. And now we have Echelon 2 data where brentuximab is approved for upfront use of ALCLs, and we have approval of ALK inhibitors in relapse refractory ALCLs in up to the age of 21, preferably in pediatric age group. That approval came this year in January. Okay, so now the objectives of today's lecture is to discuss about classification and a little bit about primary cutaneous ALCL. Then we'll discuss about a newly diagnosed systemic ALCL in terms of the epidemiology, how to diagnose, prognostication, management, chemotherapy, including transplant, and what is there in relapse refractory disease, what are novel therapies, and the role of allotransplant. Okay, so if we divide ALCL broadly according to WHO classification, this is into two mostly made. The broader classification is cutaneous ALCL and systemic ALCL. Now, systemic ALCL is again ALK positive and ALK negative. So this is according to the 2008 classification. In 2016, we have something called breast implant associated ALCL, which is a provisional entity. So this is the 2016 WHO. And as you can see, ALK negative anaplastic large cell lymphoma became a definite entity in 2016. And breast implant associated ALCL is still a provisional entity in latest WHO. I will not discuss about breast implant associated ALCL because it is not commonly seen in our country. This is a disease of Western world. We'll limit our discussion to cutaneous ALCL and the systemic ALCL. Now, we'll discuss first primary cutaneous ALCL. So, primary cutaneous ALCL comes under this broader heading of primary cutaneous CD30 positive T lymphoproliferative disorder, and it has two important diseases, that is lymphomatoid papulosis and primary cutaneous ALCL. So, lymphomatoid papulosis is so when you say primary cutaneous ALCL, it is a disease which is limited to the skin alone. We'll discuss that. It can have involvement of nodes as well, but very few patients will have that. Most commonly, the involvement is limited to the skin. Now, there is another disease that is called lymphomatoid papulosis, which mimics primary cutaneous ALCL very closely in terms of the morphology of skin lesion as well as biopsies. Important thing is that primary cutaneous ALCL are ALK negative. So that is the problem in differentiation between this different entity, or I would say the similar in terms of the presentation as lymphomatoid papulosis. So lymphomatoid papulosis, if you see the basic description, is this is written in from the WHO manual, where the classical description is the skin lesions are, you can see from this second diagram. This is typical of lymphomatoid papulosis, where there are crops of lesions. There are crops of lesions. They are not very few. There are multiple lesions which are papular and that come and go, which last for 2 to 8 weeks, and they resolve without any treatment, often leaving behind post-inflammatory pigmentary changes or scars. So this is classical description, and typically this is dealt by dermatologist, and the treatments are mostly limited to steroids and in some patients methotrexate. Now, the disease for us to understand is primary cutaneous ALCL, and this is the picture. This picture is typical of a primary cutaneous ALCL. As you can see, they are large nodular lesions, and this is also similarly the primary cutaneous ALCL. So now, as I said, in lymphomatoid papulosis, there are crops of lesion. In primary cutaneous ALCL, you can see single lesions, which are tumorous or ulcerated nodules. 20% can have multiple or disseminated lesions. The median age of diagnosis is around 60 years. As I said, very few will have involvement of sites other than skin. Only 10% can develop or involve regional lymph nodes. Now, interesting thing is primary cutaneous ALCL also has a tendency for spontaneous regression, and that can be seen in 20 to 40% patients as well. In whatever modality of treatment, the modality of treatment is mostly skin limited treatment, and we'll discuss that. But whatever modality we use for treatment, the relapses are almost seen in 40% patients. And always you have to exclude a systemic ALCL in a patient with skin limited ALCL, because there is no IHC marker which can differentiate primary cutaneous ALCL from systemic ALCL. As I said, they are ALK negative. So there is no other IHC marker which will differentiate. It is purely a clinical approach. And disease specific 10-year survival is 90%. That you can see, that means less is more, I would say, in these patients, where you should avoid multi-agent chemotherapy if possible. And mostly the treatments are limited to the skin directed therapies. So how do we treat them? So if it is very localized T1, T2 lesions, surgical excision is what is done for diagnosis also, and sometimes that is the only modality of treatment because we excise the lesion completely, and these patients can be kept under observation, or you can use radiotherapy as a single modality. There is no role of systemic therapy. Now, as I said, 10% patients can have a regional node involvement. We have to prove it by doing a biopsy. And in that case, skin limited therapies have less role. We should think about giving some form of chemotherapy. Now, the discussion between low dose methotrexate and chemotherapy has to be discussed. There is no comparison, but whatever is feasible and patient can tolerate, we should do. And as I said, less is more in these patients. So it depends on the disease bulk and burden. We should decide about the nature of the treatment. Now, if it is generalized T3, like extensive skin lesions, as I said, around 20% patients can have this kind of presentation, where multi-agent chemotherapy, mostly anthracycline-based CHOP chemotherapy, is recommended. And as I said, the disease-specific survival is almost 90%. So these patients do relapse, but they relapse again in the skin, and they can be treated again with similar kind of therapy. Now let's shift to systemic ALCL, newly diagnosed, and we'll discuss its epidemiology, diagnosis, and prognosis. So T-cell lymphoma itself is a rare disease. And as you can see, we have, these are the types of peripheral T-cell lymphomas. So starting from AITL, NK T-cell, ATLL, ALCL, and EATL. So these are all different types. So when you have a rare disease, and again, there are sub-classification, then each entity becomes again rarer and rarer. So for that reason, an international T-cell lymphoma project was started, which the main purpose of this project is to collect data from various countries, North American, European, and Asian countries, to understand the incidence, to understand the geographic variations, and also the outcomes of these patients. It's a prospective database. And this is the first paper that was published in JCO 2008. And you can see the incidence of different kinds of T-cell lymphoma, and out of which only 12% were anaplastic large cell lymphoma, both ALK positive and ALK negative. And if you see, the cutaneous variant is only 1.7%. So the incidence globally also is very low. And if you see the geographic variation, as I was discussing in my previous slide, so it again depending on how people give their data. So if you see the Asian countries, the data of ALCL is very low. The incidence is low as per the this international lymphoma project, and it is more in North American countries. And if you see, the NK T cells are very common in Asian countries as compared to North American, European countries. So there is a bit of geographic variations, but by and large, if you see the data, it seems that ALCLs are common in North American countries as compared to the Asian countries. But we have to see how many Asian countries are giving the data to the project. So now coming to the difference between ALK positive and ALK negative in terms of epidemiology. If you see the age, the median age of ALK positive group is only 34 years, which is pretty younger group of patient. And if you see ALK negative, it is 58 years. So it is a disease mostly limited to the elderly population. And now coming to the IPA score, the same IPA score that you use in B-cell lymphoma is applicable to the ALCLs, and it pretty much differentiate the outcome very well. And if you can see, the patients with IPA 3 or more, they have very poor outcome, 23 to 25% as per the data. Those who have low IPA has almost 60 to 80% failure-free survival. So now when you compare with PTCL NOS, I'll come to that in my subsequent slide. ALCL outcomes are definitely better with their respective IPA scores also. Okay, so now coming to the systemic ALCL, as I was discussing, out of total NHLs that you see, 3% in adult, 10 to 20% of childhood NHLs. So ALCLs, systemic ALCLs are more common in childhood as compared to adults. 70% present with advanced stage disease. And if you see the type of external involvement, skin, bone, lungs, marrow, liver. It is rare in gut and CNS. Male predominance is seen. And as I was discussing, ALK positive ALCL is typically seen in children and adults in their 30s, and ALK negative, the peak incidence happening late 50s. Okay, so now before 2008, the entity was mostly an ALCL, and they were ALK positive. So the entity of ALK negative ALCL was defined in 2008 by Dr. Savage from British Columbia, and he reported first that there is this entity called anaplastic lymphoma, which are ALK negative, and their outcome is definitely not it's poorer than ALK positive. But when he compared this with PTCL, the garden variety of PTCL NOS, it is still better. So if you have to see the outcome, the best outcome is with ALK positive, followed by ALK negative and PTCL NOS. Now, PTCL NOS is something which is a waste basket group where if you can't classify a T-cell lymphoma into the specific types, you put them into PTCL NOS. So earlier, these ALK negatives were actually in the PTCL NOS, but when you define them as a separate entity in the last WHO, so then now we have this ALK negative ALCL, which is different from PTCL NOS, and their outcomes are actually better if you compare the outcomes of PTCL NOS. And same IPA holds true for both ALK positive and ALK negative. Now, microscopy, I will not discuss much about microscopy, but important thing for a resident to understand is there is something called hallmark cell of anaplastic large cell lymphoma, which are typically, these are very typical cells which have irregular kidney-shaped nuclei, and they are typically called the hallmark cells of ALCL. And if they are present, they are more, I would say, pathognomonic of an ALCL. And why it is important? Because ALCLs have various morphological patterns, so which can mimic various lymphoma, so also solid tumors as well. So it's important to understand important histopathological findings. So as I said, characteristic hallmark cells and strong CD30 expression. And CD30 is also called key 1 antigen. And initially, anaplastic lymphomas were termed as key 1 lymphomas, and this is based on the key 1 antibody that was used against CD30. That's why these lymphomas are called. The way you have key 36, so similarly, this is in that particular group where you have antibody against this particular antigen. Now, these were the morphological patterns of ALCL, and starting from small cell pattern to the large cell. So you have broad spectrum of morphological pattern, which can mimic different kinds of lymphoma as well as other diseases also. Now, as I was coming here, this ALCL, I discussed in my previous slide about PTCL, NOS, and ALCL. So PTCL, NOS was, as I said, was a waste basket group where ALCL became a different entity, ALK negative ALCL. So it is important to differentiate these two entities because the approach of treatment and prognostication is entirely different. These are typical features of ALCL, ALK negative ALCL. If ALK is positive, the confusion is not there. When ALK is negative, then it becomes important to differentiate these two entities. So most important is CD30 expression. So we have CD30 expression in almost more than 75% of the lymphoma cells in ALCLs, which is not commonly seen with PTCL NOS. That is one of the differentiating point along with other histological features. Now we have got something called DUS22, TP53 gene rearrangements that I will discuss in my subsequent slides, which are various subtypes of ALK negative ALCL again. So as the histopathology is very heterogeneous, so it mimics different types of lymphoma in histopathology. It mimics Hodgkin, so it can mimic PTCL NOS, it can mimic even metastatic carcinomas also, histiocytic sarcoma and myeloid sarcomas as well. An important thing to understand is that ALK positivity do not make a diagnosis of ALK positive ALCL. It is not very specific for anaplastic lymphoma. It is we have other diseases also where ALK can be positive. Now, ALK negative group. So ALK negative group was defined in 2016 WHO as a definite entity. But again, the subclassification of ALK negative ALCL itself um, uh, uh, started before that, and this is a paper from Mayo Clinic where they have looked into different kinds of genetic rearrangements in ALK negative LCL, and
वो आपको फोन करके दिखा
yeah. So ALK negative ALCLs that have DUS22 rearrangement in FIS, they had a prognosis which is similar to ALK positive ALCL with 5-year survival of almost 90%. So this is another different group of disease, you can say, where the outcomes is excellent in spite of being ALK negative LCL. Those who have TP63 rearrangement, they have very dismal outcome, the 5-year OS of only 17%. And those who are negative for all three, like ALK, DUS22, TP63, they are called triple negative ALCL, and their outcomes is in between around 40%. And this is the paper from Mayo Clinic, and you can see that those who have DUS22 rearrangement, their outcomes is as good as those who have ALK positive LCL, which is the best group, I would say. And it is seen in 30% patients. 8% patients will have this TP63 rearrangement, and the outcomes is pretty bad. So that's how the ALK negative group again needs refinement, and probably in next WHO will see this type of subtypes coming as provisional entities at least. So now coming to prognostic factors, I already discussed about ALK positivity. It gives the best prognosis, and followed by ALK negativity. And ALK negativity again about DUS22 and PP63. The outcomes are different. Now age is an important prognostic factor. Age less than 40 and more than 40, as well as beta-2 microglobulin. Now, histopathological patterns like lymphohistiocytic or small cell component, these histological patterns have poor outcome. And this came from the ALCL 99 data. I will discuss in my subsequent slides. And IPI scores, the same that you use for B-cell lymphoma, is an important prognostic tool in ALCL. Now, let's come to the treatment of newly diagnosed ALCL and what are the important questions that we need to answer in treatment of ALCL. So what is the optimal first line therapy, and what is the role of intensification of therapy? Like what is the role of giving more intensive chemotherapy in terms of Burkitt-like chemotherapy, I would say, intensification. What is the role of transplant upfront? Do all patients need transplant in ALCL? And what is the optimal approach in relapse refractory setting? What is the role of transplant at relapse? So these are the things we'll answer in next couple of slides. So important principle, or I would say important thing to understand in ALCL is it's an extremely chemosensitive disease, both in upfront and at relapse. Unlike in B-cell diffuse large B-cell lymphoma, where if the patients have relapse, the outcomes are definitely not as good. But if you see ALCLs, they have chemosensitivity even at relapse. And if you see the event-free survival rates, in whatever protocol you use in ALK, specifically in ALK positive group, the outcomes are around 60%. And these are the different kinds of regimen. These are all single arm, retrospective or case series. These are very small data sets where the number of patients are very few. And you can see these are both in children and adults. And people have used Burkitt kind of regimen, doxorubicin kind of regimen, CHOP, and you can see the outcomes are almost 50 to 60% in terms of event-free survival, and overall survival goes up to 80%. Now, systematically, in a prospective way, first time it was studied by the Gela group, by the Belgium and French group, where they had quite a few phase 2 and phase 3 data on use of various chemotherapeutic regimens in in both B and T cell lymphomas. So this is a blood paper in 1998, and this was the time people used to use intensive therapy even in B cell lymphomas. If you can remember my lecture on DLBCL, the Fisher's paper came in 1993, where it settled the controversy of whether intensification is needed in B cell lymphomas, at least CHOP versus intensive therapy, and there was no difference. So here people have used multiple different kinds of regimens, starting from CHOP, CHOEP, backup, backup. So this result, this particular Kaplan-Meier survival curve is for the outcome of B and T cell lymphoma. So this was the first time when they found that all T cell lymphomas are not bad, and this anaplastic lymphomas were actually doing better than B cell lymphoma in terms of their outcome. And if you see the non-anaplastic lymphomas, T cell lymphomas are actually very, the outcomes is quite poor. And this was the era pre-rituximab. So if you see this 1998 paper, so this is pre-rituximab era, where ALCL outcomes are actually better. Of course, when rituximab came with B-cell lymphoma, the outcomes of B-cell lymphoma is now almost 60 to 70%. So now this is the update of this study. This is the 8-year follow-up of this GALA study, where, as I was discussing, they have used backup, ACVP, CHOP, and CHOEP's kind of regimen. And this is one of the largest prospective data of ALCL. 138 adult patients with ALCL of around 46% patients were ALK positive and 54 were ALK negative. So when they compared the outcomes of around 100 patients who received intensive regimen like ACVP on backcord versus CHOP kind of regimen with age less than 65, there was no difference in outcome. So this paper somehow established that you may not need intensive therapies in adult, and CHOP kind of regimen is as good. I would say this paper is similar to the Fisher's paper for B-cell lymphoma for CHOP versus intensive therapy. So now the similar kind of result also came from international PTCL project that I discussed. So this is a registry data where it's a prospective data where the data is collected from various parts of the world. And when they found when you use anthracycline based treatment, the outcome of ALK positive group is the best, is in the tune of 70 to 80% of overall survival, followed by ALK negative. And then that follows the different other kinds of T cell lymphoma. And you can see the other T cell lymphomas are not doing very well with anthracycline based regimens. So anthracycline based treatment is still good for ALK positive and ALK negative with pretty fair amount of cure rates. Now, what is the role of etoposide? So that is adding etoposide to CHOP, that is CHOEP regimen. So this was studied by German high-grade non-Hodgkin's study group. So again, they have multiple prospective studies where they're looking at CHOP, CHOEP 14, that is giving CHOEP every 14 days. So this is a comparison of CHOP versus CHOEP. It is not a direct comparison in the study, but as it is a prospective study, that's what is that's the good thing about this particular paper. And they have divided patients into 4 groups: ALK negative ALCL, ALK positive AITL, and PTCL unclassified. So these were the type of patients classification or type available at that time when the study was done. And if you see the number, 78 patients are ALK positive and 113 are ALK negative. So now when they looked at the ALK positive group, so this C Kaplan-Meier curve is for ALK positive group. And when they compared those who received etoposide versus no etoposide, there is 34 and 21 patients only. And you can see the difference between that. It's a huge difference in terms of event-free survival. But when they removed the ALK positive group, and then they looked at etoposide, but there was no difference. There is no statistical difference. Of course, there is a numeric difference in terms of event-free survival. So that somehow established that probably ALK positive group do need etoposide. Now, what is the role of etoposide other than ALK positive group like ALK negative and other PTCLs is not very clear from this paper. From this paper, it seems that it is not helping much. But in ALK positive group, definitely this paper has shown that if you add etoposide to CHOP, that is CHOEP kind of regimen, it improves event-free survival. And that's how CHOEP became a kind of de facto regimen for mostly for ALK positive ALCLs. Okay, so now what is the role of upfront autologous stem cell transplant in PTCLs and specifically in ALCLs? So this is a Nordic group study. It's again a prospective study where they have used CHOEP14 as a chemotherapy backbone. They have taken patients of ALK negative, PTCL, NOS, AITL, and EATL. Remember, there is no important. There is no ALK positive here. So ALK positive ALCL, as I discussed, the outcomes are anyway 70%. So that's why that group was not included here, and this was studied only in these 4 groups. And conditioning regimen used was BEAM, median follow-up of 60 months, and you see the ALK positive, ALK negative group, ALCL, ALK negative ALCL, the 5-year event-free survival PFS is 60 with OS of 70, almost reaching to the level of ALK positive ALCL outcomes. So that's how this is one paper. If you see the historic data from Dr. Savage from British Columbia, this is only 35 to 40%. 40, I would say 40 to 45% is the historic data. And if you compare from the historic data, it looks that in ALK negative group, if you do upfront stem cell transplant, the outcomes are better. We don't have a randomized study yet to prove that claim. Okay, so now let's come to the most recent study in ALCL, I would say PTCL NOS, is Echelon 2 study. It was a double-blind, double dummy because brentuximab was replaced with vincristine in the interventional arm because there was concerns of cumulative neurotoxicity. So that's why double dummy. And it's a global study. And if you see the population studied was adult patients who have at least more than 10% expression of CD30, because as brentuximab was a CD30 targeted ADC, so we need more than 10% CD30 expression. Almost 450 patients, a huge study. And what are the patients included? There were systemic ALCL, including ALK positive, but this should have an IPI of 2 or more, ALK negative, PTCL, NOS, AITL, ATLL, EATL, and hepatosplenic gamma delta lymphoma. So all kinds of PTCL, but predominantly almost 75% patients were actually ALCLs. Okay, so this was the question they asked using CHOP versus CHOP plus brentuximab, then without vincristine. So remember, they didn't use CHOEP here, right? So this was a CHOP kind of comparator. The primary endpoint was progression-free survival as per branded central review. And in the PFS endpoint, these were the events for progression-free survival here. Documentation of relapse, progressive disease, death due to any cause, or a receipt of any subsequent systemic therapy to treat the residual disease or progressive disease. And they have excluded RT and stem cell transplant. They are not considered as events here. Okay. So these are the initial results, the 3-year progression-free survival. And you can see that the 3-year PFS is 57% versus 44% if you add brentuximab. And when they did a BICR assessed PFS, when events are only limited to progression. So as I said here, when the events are progression, relapse, death, or receipt of any subsequent systemic therapy. So when the analysis was limited to only progression or death, still, if you see, it was statistically significant. Now, in the subset of patients who had only ALCL, the estimated PFS difference was actually better, 59.8, almost 60% versus 48% for the CHOP. Now, this is the update, 5-year update that was presented in this year ASH. And as you can see the numbers here, most of the patients, almost 162 patients actually are ALCL. So almost 75% patients are ALCL. So whatever benefit that you are seeing in this study is driven by the benefit in ALCL group. And if you only limit your benefits, it's 12% benefit in ALCL group. And if you see the PTCL NOS group, the benefits are not very great, and that's not also statistically significant, as also the AITL group. So the benefits in other groups are small and questionable. And this long-term update actually validated the ongoing benefit of using brentuximab in ALCL specifically. And this is practice changing and also is recommended as first-line treatment with CHOP. Now, then if you are using brentuximab upfront for all patients, then what is the role of stem cell transplant? So as you have seen, I have shown the Nordic data which has shown that doing an autologous stem cell transplant upfront in ALK negative ALCLs, the outcomes are pretty better than historic comparisons. So this is an abstract. The full paper is not published yet. This was presented in 2019 ASH meeting, and the analysis was limited to only patients who underwent a transplant. And when they looked at ALK negative group who received brentuximab, the 3-year progression-free survival was actually quite good. It's 80% versus those who didn't receive transplant. Of course, there are multiple biases here in terms of the patients who undergo transplant, their fitness, their disease biology. But having said that, if you see those who underwent transplant, their outcomes looks better, and that's how somehow it's important to understand that those who receive brentuximab and achieve a good response, if they are ALK negative, they should undergo a autologous stem cell transplant. Now, if I summarize what I discussed about systemic ALCL management, anthracycline-based therapy is important, and an intensification of therapy like Burkitt-like regimen in adults specifically. I'll come what happens in AYA. In adults specifically, there is no benefit. Now, role of etoposide is good if you see the German data. Only mostly it is limited to ALK positive group. So if a patient is otherwise fit, less than 60 years, you should use CHOIP kind of chemotherapy. Now, BV-CHP is the new standard of care if the patients have money or means to take it. Now, transplant, autologous stem cell transplant upfront should be limited to ALK negative group. And ALK positive high IPI. Now, I told about ALK positive group, they do very well. But if you see the ALK positive high IPI is one group which are they are not doing that great. Whether you should do transplant in those group or not, that's still not settled. Now, whether you need to do how you want to treat now AYA, that is adolescent and young adult, whether the treatment approach is different as compared to adults. So till now, is there any question? No. So there are no questions. We'll proceed. Okay. So should AYA be treated differently from adult? So this dilemma also is there in treatment of high-grade B-cell lymphomas. If you see my previous presentation on DLBL, so if you have an AYA age group, whether you should treat like a pediatric approach by intensive therapy or you treat like adult by just giving R-CHOP. So the management principles in pediatric is like this. They need aggressive treatment, multi-agent regimen. So now they have two different therapeutic strategies. Whether one is short duration pulse B-like therapy like BFM approach where you treat the patients like Burkitt kind of regimen. And the second is long duration protocols, the way you treat like ALL. Vinblastine is a highly effective drug for salvage. High relapse rate, but high response to even salvage chemotherapy, unlike other lymphomas. That's important to understand. I also alluded in previously that even if these patients relapse, they have good response to salvage treatment. So short duration approach is feasible. And this is a comparison from two European protocols, BFM and UK group. And if you can see those who use short duration Burkitt-like protocol, the outcomes, the EFS is better. So this is one protocol that we use in our patients of AYA, that is called protocol ALCL 99. And this is a multi-center study using a Burkitt kind of chemotherapy backbone, intensive chemotherapy backbone, short duration. And this study had two objectives. And one was, if you see the methotrexate dosing in intensive regimen BFM studies, it is 1 gram per meter square over 24 hours. So this study was asking whether you can come down on the duration of methotrexate to 3 hours from 24 hours without giving any intrathecal. That means you avoid the intrathecals, because when you use 1 gram per meter square over 24 hours, you have to also give intrathecal methotrexate. So if you come down to 3 gram per meter square over 3 hours without intrathecal, and it will have two important implications. One is the mucositis toxicity will be less, and also you avoid the intrathecal injections. And whether that is okay, and is there any detriment in terms of overall event-free survival or prevention of CNS LM? That is one question. Second was, if you add vinblastine to the existing regimen, whether it adds or improves the event-free survival. So why vinblastine? Because in the relapse setting, I will show in my relapse refractory slides, where vinblastine single agent has shown phenomenal efficacy in terms of response rate. So that's why this trial was looking at whether you can add vinblastine to the intensive regimen. So this was the CNS prophylaxis randomization. And when the schedule of methotrexate was reduced to 3 hours, 3 gram without IT, it was the outcomes were same. So that means it became a de facto new standard, that is 3 gram over 3 hours without IT. So that's what we use in our patients when you use ALCL 99 protocol. Now the second question, that what is the benefit of vinblastine? So when they added vinblastine to this intensive regimen along with maintenance as well, there was no benefit of in terms of event-free survival. So now this is the long-term update of ALCL 99 that was published last year, and this is the 10-year event PFS. It is 70%, and it plateaued almost after 5 years. You can see there is hardly any relapse that is happening from 5 to 10 years. So the relapses are quite less, and there is a plateau. And if you see the overall survival, 90%. So that says that if your event-free PFS is 70 and the OS is again going to 90, that means you have patients who can still be salvaged and they can receive subsequent therapy in terms of transplant, and they could have a good overall survival as well. So that is interesting to note about anaplastic lymphomas. Now this small cell and LH pattern that I was discussing in my prognostication slide came out as a very important prognostic factor, and the outcomes of these patients who have this particular morphological pattern is in the tune of 30 to 40% as opposed to 70%. Okay. So why then vinblastine failed in first line? I will show the data of relapsed refractory setting. There are multiple hypotheses. In ALCL 99, it delayed relapses, but it didn't have improvement in overall event-free survival. Probably a longer duration was needed, and something to do with immunology in the first line setting. So interestingly, when vinblastine efficacy in ALCL is mostly related to its immune modulatory function as opposed to the chemotherapy mediated function. So if this is an interesting work from Japanese group, so what they did is that when they gave vinblastine to a immunocompromised, severe combined immunodeficient mice, the efficacy was not there, but when they gave it to a immunocompetent mice, the efficacy was pretty good. So that's how the conclusion of this paper is that vinblastine helps in activation of dendritic cells, and that improves the immune functions, and it acts by an immunotherapy mechanism against ALCL as opposed to chemotherapy. So when you combine with an intensive regimen, probably you are diluting its the way it acts, and that's why it is not helpful. It is a good hypothesis to, and then it probably that's why single agent vinblastine is showing a phenomenal result in relapsed refractory setting. So if I summarize, adolescent and young adults should be treated with intensive protocol. So remember, I told about adults. Adults do not need from the GALA data. So now there is no role of transplant if you're using intensive therapy upfront in AYA group. Now, what is the upper age? If you see the ALCL 99, they have used up to 21 years. Now, in our institute, you can use up to 30 to 35. Depends on the fitness of the patient to receive that kind of intensive therapy. Now, if you see the comparison of using brentuximab versus intensive therapy, that's a separate question altogether. But if you have an adolescent young adult up to 25 years, it is fair to use like an intensive therapy. Up to 30 years, beyond 30 years, we have to see the fitness of the patient. Okay, so what are the answers we got? Should ALCL be treated like DLBL? Probably a reasonable approach in adults. But should ALCL be treated like other PTCLs? No, because it needs approaches like BV-CHOP is the new standard of care. You need to add etoposide if it is ALK positive. Now, should therapy vary based on subtypes? As of now, if you have ALK negative, but you have DUS22, you have P63, whether the therapy is different, yet we have this is not standard of care. ALK negative ALCL has to be treated with a standard protocol. There is no subtype specific approach. Probably in future we may get answers for that. So what is the role of intensifying therapy upfront? Yes, in adolescent and young adult, we should consider giving intensification. And if what is the role of transplant? In ALK negative group, they should undergo transplant if they are not receiving intensive therapy. So what are unanswered questions? The patients who have ALK positive and those who have high IPI, their outcome is not good as compared to those who are low IPI. So whether they should receive transplant if they're receiving CHOP or CHOP kind of backbone, we don't have the answers for that. And as I said, ALK negative group with DUS22 rearrangement, they do very well, even if they are ALK negative. Do they really need transplant? So these are questions to be answered in future. Now, what is therefore in relapse refractory disease? So in relapse refractory disease, you have brentuximab, that's an ADC targeted against CD30, and you have ALK inhibitors. So ADC, all of you know, we have an antibody drug. This is an antibody drug conjugate. We have a chemotherapy attached to an antibody with a linker. So now the antibody is targeted against a specific antigen in the tumors, and that leads to a tumor-directed delivery of the chemotherapy. So brentuximab is again an ADC with the target against CD30, and the chemotherapy is auristatin E derivative. So this is the phase 2 data of brentuximab in relapsed refractory setting. The primary endpoint of this study is overall response rate. 58 patients, almost 70 patients were ALK negative ALCLs. 62% patients had primary refractory disease. Median line of therapy was 2. 26% patient had prior history of autologous stem cell transplant. And if you see the objective response rates, 86% of using only single agent brentuximab with 57% CR rate. And the PFS at 1 year was 70. So the benefits in this particular group is nominal if you use single agent brentuximab. Now, what is the role of doing transplant at relapse? So we discussed about transplant upfront from the Nordic data. This is a very interesting paper from, again, the ALCL99 group, which has a second study of doing randomizing, or I would say a prospective phase 2 study of doing transplant in patients who relapsed after receiving ALCL99 protocol. So those who received an intensive protocol upfront and they relapse subsequently, how do we salvage them by doing autologous, allogenic, and what chemotherapy? So this study had 3 objectives. One is, what is the role of, so first is they have divided the patients into 2 groups, high risk, intermediate, and low risk. Now, high risk are those who progress during first line therapy. Intermediate are those who progressed after they completed treatment, again, depending on the CD30 positivity and CD30 negativity. And if those who are CD30 negative but who relapsed within 1 year, again, they come to intermediate group. Those who relapsed after 1 year, they are low risk. So low risk is those who have relapsed after 1 year of their previous therapy, and those who are CD3 negative, and they didn't receive prior vinblastine. So if you remember, ALCL99 had one arm of testing vinblastine in the intensive protocol. Now, those patients who are high risk, they received allotransplant. Those who don't have a match in the intermediate group, they want to go autotransplant. The third group, that is very low risk, they only received single agent vinblastine. They didn't want to go any kind of transplant. So you have 3 interventions here. One is allotransplant in very high risk, intermediate risk group auto. If they have a match, they go for allo. And those who have very low risk group, they only receive vinblastine. Now let's see the outcomes. So if you see overall outcome of this patient, 50% event-free survival, 70% OS. So that is in a relapsed disease. So as I was discussing, it's a chemosensitive disease, and when you do transplant at relapse also, the outcomes are still 50% with 70% OS. Now, if you see the intermediate group, this was the intermediate group where few patients underwent allo and few underwent auto, depending on the donor availability. And if you see the difference, 78 versus 30. So those who underwent an allotransplant, their outcome was phenomenally well. And the interesting thing was that the outcome of autotransplant relapse setting is only 30%. And the third group, that is low risk group, who received only single agent vinblastine, 19 patients, out of which 1 received auto and 1 allo, their 5-year survival is 80%. They didn't undergo any transplant, neither auto nor allo. So only single agent vinblastine, the 5-year EFS is 80%. And this is the difference in the intermediate group. You can see auto versus allo. So is this the end for auto transplant in relapsed ALCL? Likely it seems, because the outcomes are not as good as you expect in an autologous stem cell transplant. So we have options of, if the patient have a full match and allotransplant is feasible, I think that should be the way to go. Now, this is the data of single agent or single drug vinblastine, a French study. The study is very small, but it is a JCO paper. The reason being, 36 patients, 15 patients out of 36 had a history of transplant, and the drug used was only vinblastine 6 milligram per meter square weekly. And if you see the response rates, which were 25 patients out, 30 patients were evaluable, and 25 attained a CR. 80% response rate only using single agent vinblastine. So this paper actually led to the enthusiasm of adding vinblastine upfront, and you see it failed. So that's how the immunology of vinblastine. If you are using in a relapse setting, you get phenomenal responses, and if you have used in an intensive backbone, there is no difference. So this is the crizotinib data from the COG group, a phase 1 study based on which the crizotinib got approval. And if you see, there's patients who have ALCLs, refractory disease. It was tested in all different solid tumors also, along with anaplastic lymphoma. And the patients who had anaplastic lymphoma, you can see they attained CR, and in a very few group of patients. And this led to the approval of crizotinib this year, based on only 26 patients, though up to the age of 21 years. And the interesting thing about the response is 80% underwent CR, but what is the durability? 39 maintained up to 6 months, only 22 maintained up to 12 months. So the durability of response is a concern, though they achieve excellent CRs. The recommended dose was 280 milligram per meter square twice daily. That's little higher dose as compared to that used in lung. That's why the toxicities are also very high. If you see the ocular toxicities occurred in 65% patient, 90% patient develop GI toxicity. So adverse reactions are high because of the higher dose. Now, durability of response, as I said, is a concern. So there is one study that is enrolling of adding crizotinib with vinblastine. You achieve that excellent response, and then to maintain that response, you use vinblastine. That study is enrolling. Probably that is the way to go, because you have good responses, but durability is a concern when you use these targeted drugs. So if I want to conclude, in a relapse refractory setting, brentuximab is a good way to bridge to transplant. Chemotherapy-based salvage, you can use ICE or GDP, depending on the feasibility. If the patient have early relapse, then the outcome of auto transplant specifically is very poor. Those patients should be counseled or work for allotransplant. Late relapses, we should think about, or we shouldn't forget about single agent vinblastine, the phenomenal data that you have shown from French group, and the ALK inhibitors, that is very recent. Okay, so thank you. And, yeah, I finished in time. Thank you. Okay, so there are no questions in the chat box.
Hello.
Yes, ma'am.
No, I just wanted to say, I think from the ALCL perspective, at the diagnosis, as you rightly mentioned, that, a lot of them, like somebody presenting with a supraclavicular node, that ALCL and squamous cell carcinoma may be a diagnostic dilemma, and maybe looking at, looking at other features and other sites and having a high suspicion. So I think that is what would be important.
So Amit has asked for elderly, any change in protocol? For elderly, if you see the brentuximab data, the Echelon 2 data, the patients were enrolled up to the age of 65. So now the patients who are elderly, there is no good data whether they will tolerate brentuximab based regimen. So above 65, preferably it is CHOP. You can't add even etoposide, because the etoposide data from Germany is also less than 60 years. So this year, as we have a couple of papers of using brentuximab with etoposide backbone in elderly patients. So that is one thing which can be given if you want to avoid anthracycline and then add brentuximab. But for elderly patients, I would prefer giving CHOP-like regimen if anthracycline can be delivered, or COP, that is avoid anthracycline and adding brentuximab. So we had one patient which positive ALCL who was 67 years, if I remember correctly, and whom we treated. He had some concern for not using for anthracyclines. He had some cardiac comorbidities, so he used COP with brentuximab, and he went into CR. And though he relapsed later on, his tolerance was pretty good. So in that way, I would say using brentuximab even in elderly is feasible, but we have to be careful with its toxicities, specifically neuropathy. Our experience with single agent vinblastine, yes. So our experience are limited to only few cases. So we have, I would say, I can't give you a number, but we have patients who have phenomenal response with single agent vinblastine, and we have patients who have responded to vinblastine, went into CR. We did autologous stem cell transplant. They relapsed after 3 months, and again we gave vinblastine. They went into CR. So and we have other patients also who have didn't undergo transplant, who had late. But the typically important thing to understand is that those patients who have delayed relapses, probably these are the group which, as you see the ALCL 99 data also, those who have relapsed after an year and limited disease, probably single-agent vinblastine seems a good idea. And doing transplant, those who achieve CR to single-agent vinblastine, we don't know whether that helps or not.
So how long we continue vinblastine in these?
Yes. So I have one patient whom I continued for 2 years. So this is in the ALCL 99 also they have made that provision to continue. They have given that limited duration therapy. But I have one patient whom I've continued for 2 years and then I stopped. So now it seems he is again relapsing. So it has some immune mechanism, but whether it leads to cure, even if you stop, you don't know. But if I have to limit the duration of therapy, it is 2 years. Madam, Manju Madam, if she's there, she can comment on that. What should be the duration? Madam, I think has not joined, or Bhau Sahib, sir. No, sir also has left. Okay, Kunal has asked. Did I answer your question, Akhil?
Yes, definitely.
Yeah, thank you.
So we continue weekly only till 2 years?
Yes, we give weekly, 6 milligram per meter square weekly.
Okay. Thank you.
ALK positive DLBCL versus ALK positive ALCL. So, what is the question, Kunal? Like in terms of treatment or diagnosis? What is your question?
So, clinical and treatment related difference.
So, ALK positive DLBL again is a rarer group of DLBL. So that's what I told on one of my slides, that only ALK positivity doesn't make a diagnosis as ALK positive ALCL. So there are DLBCL also where ALK ISC is positive. They are typically CD20 negative, so you can't use rituximab in those patients. Now, coming to treatment, there is not much data in terms of which regimen is better. But if the patient is fit to receive any intensive therapy, then it should be preferred. But the outcomes are very poor, so that's why typically what we give is CHOEP or EPOC kind of regimen, either CHOEP or EPOC, whichever is feasible. If dose as a EPOC is possible. If not possible, you can give just CHOEP that we use in ALK in ALCLs by adding etoposide 100 milligram per meter square for 3 days with CHOP. Now, ALK positive, again, it depends on the age and fitness to receive intensive therapy.
Lingraj, if I can add to that question of vinblastine in relapse refractory setting.
Yes,
there is data from the adolescent, I think pediatric adolescent age group, where they use vinblastine and they have used it indefinitely till progression or intolerance. And what you said, no, they have noticed that when they stopped the vinblastine earlier, they saw relapses happening even if after 2-3 years of usage. So the data in relapse refractory DLBCL, if you're using single agent vinblastine, favors that you use it indefinitely till progression or intolerance. This, I think, is a JCO publication. I'll send you that link.
Okay, sir. Thank you. Okay, are there any questions? If not, then I'll hand over to Kumar sir.